Dr. West, please start. Thank you. Bismillahirrahmanirrahim. Today, I will talk about nutritional rehabilitation. I am Dr. Muhammad Daood, and I am doing my fellowship under supervision of Dr. Professor Saira Afzal. Today, we will learn about the nutritional rehabilitation, its types, its phases of nutritional rehabilitation, and what are the nutritional rehabilitation center in different shapes and forms are working in Punjab and other part of the country. And also we will talk about the Pakistan Nutritional Survey finding by UNICEF. And by the end of this presentation, I hope you will be able to understand about what are the nutritional rehabilitation strategies currently being employed and the role of integrated management of maternal newborn child health program and the community-based management of acute malnutrition. And we will discuss about it, and also we will discuss the Pakistan and global updates. Nutrition for everyone, that's a slogan by the UNICEF, and it's a strategy document from 2020 to 2030. Have been compiled in collaboration with other partners like WHO and UNICEF. They are the guidelines for the future, for the next decade. Let's start with the definition. Nutritional rehabilitation is basically a practical training which is imparted to the mothers of the children with malnutrition in selecting and preparing the food from locally available cheap sources. That's the important part here, is that is selection of and preparation of the food from locally available and cheap sources and feeding them back to the health. That's what nutrition rehabilitation means. There are different types of nutritional rehabilitation. It may be the hospital-based, maybe center-based, or the nutritional rehabilitation center, residential nutrition rehabilitation center, and most important, community-based nutritional rehabilitation centers. These are the different types, and the interventions which we do for the preventing the malnutrition are the nutritional supplementations, specific nutrient supplementations, nutritional therapy. Nutritional rehabilitation is one of the part of the interventions, and the nutritional education. Just to remind you about, we have already learned about the various types of malnutrition, but here, just to understand the rehabilitation, we have to recap what we learned about what are the moderate acute malnutrition, moderate or severe acute malnutrition, or the global acute malnutrition concepts. The moderate acute malnutrition is weight for height, and defining the z-score between -2 and -3, or mid-upper circumstance between 11.5 centimeter and 12.5 centimeter, or in millimeter. You can see here. And the severe acute malnutrition is weight for height z-score is less than -3, or mid-upper arm circumference is less than 115 millimeter, or presence of bilateral edema, or both. That's important here for the acute malnutrition classification. And there is also a third term here, the global acute malnutrition. It refers both to moderate and severe acute malnutrition, and it is used as a measurement of nutrition status as population level, and is indicator of severity of emergency situation. As far as the nutritional rehabilitation centers are concerned, you see the management of the malnourished children doesn't require sophisticated facilities and equipment or highly qualified personnel, and the children are treated with proper care and affection, and each phase of treatment can be carried out properly by approximately trained and dedicated professionals or personnel. When this is done, the risk of death can be reduced, and opportunity for full recovery is greatly improved. In the uh, Nutrition Rehabilitation Center, after treating life-threatening problem in a hospital or in a residential care facility, the child with acute malnutrition will be transferred to Nutritional Rehabilitation Center for intensive feeding to recover lost weight, development of emotional and physical stimulation, capacity building of primary caregivers of the children and with acute malnutrition through sustained counseling and continuous behavioral change activities. So you see here the Nutrition Rehabilitation Center, they act as a bridge between the hospital and home care. So Nutrition and Rehabilitation Center are basically the homestay for children with acute malnutrition along with the primary caregivers. The objective, these are meant for to provide the nutritional care for children with acute malnutrition, to promote physical, mental, and social growth of the children with acute malnutrition, and the purpose is also to build the capacity of the primary caregivers in home-based management of malnourished children. Really, the admission criteria is one of these: the severe wasting or bipedal edema, moderate to severe cases with complication like recurrent acute respiratory infections and diarrheal diseases, and yeah, the age is less than 1 year, with lactation failure or mother expired, and the children associated with associated problem can only be admitted after stabilization at primary healthcare center for recommended period as decided by the treating physician at a nutrition rehabilitation center. The services which we usually provide in nutrition rehabilitation center are the treatment and management of the patient, nutritional support to inmates, nutritional education to his or her family members, and other counseling services like family planning, better hygiene practices, psychosocial care, and development. And we also do, along with all of this, there's ongoing activity, which is the capacity building of the primary health caregivers on preparation of low-cost nutrient diet from the locally available food ingredients. And so they're developing feeding habits and time management in mothers and imparting knowledge of developing kitchen gardens, etc. And of course, they provide the nutrition and rehabilitation center also provide the follow-up services. Who are at risk of developing moderate and severe acute malnutrition? Are people who are having inadequate dietary intake, having inappropriate feeding, fetal growth restrictions, inadequate sanitation, lack of parental education, and the family size, the number of children in the family, or the immunization status, the poverty, economics, politics, and environmental instability and emergency situations are also part in role in putting the children at risk for the developing of moderate and acute malnutrition. Here you see a web of factors which come into play when we talk about the nutrition of mother and children. You see here, apart from the efforts put at the government or private sector level, you have to consider the resources, and resources not only include the financial resources, but are importantly are environmental, social, and human resources. And you have to consider about the cultural habits, norms, and taboos associated with the food and feeding practices. And you see here, not only the availability of food, but the feeding practices play an important role here. The age-specific dietary practices, including responsive feeding and stimulation in early childhood with adequate food preparation and food consumption and hygiene practices are important, which give the input to both to diet and care, along with the important factor here, the environmental sanitations and adequate nutritional health and sanitation services in the environment, and that in the diet component, adequate diet for feeding and the care by the mother and the caregiver and the practices for the children. These are the immediate determinants, and eventual come out is, if they are in the line, the eventual outcome is in the form of improved survival, physical, social, mental growth, and social performance is, and productivity is improved in the both in the mother and child. Sorry. Here is the 10-step formula, 10-step, I mean the flow chart step given by the World Health Organization for management of acute malnutrition. We talk about the rehabilitation. So you can see here that after initial treatment of hypoglycemia, hypothermia, and dehydration, in the rehabilitation phase, we start although the correction of electrolyte balance starts in initial treatment phase, and it continues go into the rehabilitation phase also, along with the correcting the micronutrient deficiencies which have been started in the initial treatment phase, and it is continued in the rehabilitation phase also, and along with the phase which is all along the from very basic, from the very first day, is the stimulation of emotional sensorial development. And the factor here, you can see the increased feeding to recover the weight loss is the main activity here in the rehabilitation phase to catch up the growth and to rehabilitate as rehabilitation of the health status as he or she was previously. So here you see that after initial treatment of hypothermia, hypoglycemia, dehydration, infection, electrolyte balances, and micronutrient deficiencies are corrected in initial statement, but in rehabilitation, electrolyte balance and micronutrient continue to be corrected, and iron is added. More importantly, here you can see here, if I go back to the previous slide, here you can see the nutrient deficiency starts is being corrected. Here you can see the correction starts from the initial treatment phase, but when the rehabilitation phase starts, the iron component is added in the rehabilitation phase, and and the feeding is increased to stimulate the catch-up growth, and children and are prepared for discharge. And the follow-up, increased feeding is continued to recover the lost weight. In the rehabilitation phase, what we do is that during rehabilitation phase, F17 formula, we will learn about what is the F75 and F100 formula. The F75 should be replaced with the F100 formula in the same amount for 48 hours before increasing the successive feed by 10 millimeter until some remains unconsumed. As I said, F75 and F100 formula, these are the two formulas which are used for the rehabilitation phase. And here's a guideline that during rehabilitation phase, the F17 formula is replaced with the F100 formula in the same amount for 48 hours before increasing the feed. If available, the children should be transferred from F75 to RUTF, which is readily used therapeutic food according to the updated WHO guidelines. Children's respiratory and pulse rate are important to be monitored before transition, and after transition to F100 formula, children should receive feeding consisting 100 to 200 kilocalories per kg per day and 4 to 6 gram protein per kg per day at least every 4 hours. And of course, breastfeeding is continued here also if the child is less than 2 years of age. In the follow-up phase, after recovery, parents are taught to feed the children frequently with a high energy and nutrient-dense food, and to continue the stimulate their children's sensorial and emotional development. And parents are requested to bring the children back for the regular follow-up. And vitamin A supplementation is here important for supplementation, and booster immunization should be provided. Vitamin A here you can see that is as important because not only prevents the infections, but also helps in rehabilitating or gaining the weight, like the other micronutrient you see there when in the diarrheal disease you use the zinc. Community-based treatment here, community-based management of acute malnutrition is the model which strives to reach all severely malnourished children before development of medical complications. This model uses community workers, like here in our country, the community midwife or uh, LHWs to actively find cases of wasting within the community. Children are screened to assess their nutritional status, typically using mid-upper arm circumference cutoff value and simple algorithm to assess the presence of medical complication, which would necessitate referral to a facility-based treatment program. And in this program, only about 15% of children with severe acute malnutrition have medical complications that require inpatient treatment. And in this community-based model, mother administer RUTF formulas to their children and for the rapid change in the children's condition. This provides the positive feedback those who are associated with recovery process, and it strengthens the community motivation for case finding and case referral. The community-based management of acute malnutrition actually is a program developed under a community therapeutic care model and was implemented in early 2000. Achieved recovery rate was almost 80% and case fatality rate of less than 5%. In this model, they were studied more than 75% of children treated for malnutrition in this program were treated on outpatient basis, reducing the opportunity cost to caregivers. In this model, it is based on 4 principles. That is to give the maximum coverage and access, timeliness, appropriate care, and care for as long as it is needed. Community-based treatment, WHO recommend that children should be enrolled and discharged from the treatment using the same mode of classification. And that means the children who are admitted based on mid-upper arm circumference should be discharged once their mid-upper arm circumference is more than 125 millimeter for at least 2 weeks, or weight for height disease score is more than -2 for at least 2 weeks. Children who were admitted based on their edema should be discharged based on the measurement routinely used in the program. And once discharged, children should be followed periodically to avoid relapse. WHO further recommendation are the children who are treated with fortified therapeutic food should receive a high dose of vitamin A on admission. Children who receive therapeutic food, they don't need the high dose of vitamin A because it already contains vitamin A. And RUTF should also be given to children regardless of whether they have diarrhea or not. Here's a nutritional component of integrated management of maternal, newborn, and child health program. You know that in Punjab, this program is an integrated program, as the name indicates. Basically, the 3 programs have been merged in this program. One was the maternal, newborn, child health program. Second was the Minister program for family planning and primary health care, and third was the nutrition program. And these 3 programs have been integrated into IRM and CH program. And the nutritional component of this program emerged in 2010 when a special initiative was launched in severe flood affected districts for provision of malnutrition treatment. The BHUs of nearby flood affected areas were selected for this purpose, and outdoor therapeutic program, OTPs, counters were established at these BHUs, and stabilization centers were set up at district level, DHQ levels. And till 2014, it was supported by UNICEF and WHO, but thereafter it has been taken up by the program IMCH, and malnutrition is the major problem in our country. So the government has decided to scale up the OTPs of outdoor therapeutic program counters to selected BHUs and stabilization center to all BHUs and teaching hospitals. Scope of basically these services is the screening of the children and pregnant and lactating women in the community level by the LHWs and the facility level by LHVs and OTVs, and preventive services are also provided through LHWs, including in the provision of iron folic acid tablets, multi-micronutrient, sachet, low RS, and zinc for diarrhea cases. Both moderate and acute malnutrition treatment and counseling services are offered at OTPs, and complicated severe acute malnutrition children are referred to the stabilization center. And each of the stabilization center has an OTP counter attached to it. Checklist, how you can assess the children who are at risk for developing malnutrition. And these are the insufficient household food security, low birth weight, weight loss or no weight increase in the children for 3 consecutive months, household with a history of malnourished children, death of under 5 children in the same household, lack of child spacing, childhood orphanage and single parent household. These are prone to develop malnutrition. And what the community can do at their own level, as far as the nutritional activities are concerned, improving the food availability at household level by promoting kitchen gardening, income generation by providing production and creation of markets, and access to food by the government, and supply of the seed and plants, supply of livestock for breeding, improved utilization of food by improving the knowledge on nutritious food groups, and demonstration of cooking, and to build the skill of community health workers and the support groups. The diets used basically for rehabilitation are 2 types of based. These are milk-based diets. These are highly energy liquid diets used in hospital rehabilitation, and they need accurate dilution and clean water, and water content supports bacterial growth. Must have to be taken into consideration, and they need to be utilized immediately. And the other is ready-to-use food powder, which is good for home rehabilitation, oil-based, and it doesn't have any water and doesn't support the bacterial growth. These are the brief description of what are the F75 and F100 formulas. As I discussed earlier, basic used for rehabilitation of the children of malnutrition. Basically, the F17 formula is a starter formula used during initial management of malnutrition, beginning as soon as possible and continuing for 2 days until child is stabilized. And severely malnourished children cannot tolerate normal amount of protein and sodium or high amount of fat, so they may die if too much is given to them. So they also need glucose, so they must be given a diet that is low in protein and sodium and high in carbohydrate. And F7 formula is specially mixed to meet the child needs without overwhelming body system in initial stage of treatment. So use of F75 formula prevents the death. And mostly must remember that F17 formula contains 75 kilocalories and gives the 0.9 gram proteins per 100 ml. And feeding formula F100. F100, as you see that as soon as the child is stabilized, F75, F100 is used to catch up formula to rebuild the wasted tissues, and it contains 100 calories and 2.9 proteins, 2.9 gram protein per 100 ml. And the recipe, most importantly, this recipe doesn't require any cooking, as they do not contain the cereal flour. Here is the composition of F75 formula. You can see if you can have 3 recipes depending on the type of milk you have. If you have dried skimmed milk, you follow the first one, and you have dried whole milk, and then the second one is there. And if you have the fresh milk, fresh whole milk is there, then the formulation is slightly different, but the other contents are the same, like sugar, cereal flour, vegetable oil, mineral mix, and making it whole up to 1000 ml. This is a bit detailed description of 2 formulas, F100 formulas. You can see here there is no cooking is required in the F100 formula. Again, here the three type of milks: dried skim milk, dried whole milk, or the fresh milk are used depending on. And here you can see here the contents are only sugar, vegetable oil, mineral mix, and water. And mineral mix is the sachet containing vitamins and minerals uh, in a powder form. It was all about the F100 formula. Here you see an update from a recent systematic review in 2019, based on studies in India, Malawi, Zimbabwe, Cambodia, and other 8 countries. This systematic review came up with the conclusion that compared to alternative dietary approaches, standard RUTF probably improves recovery and may increase the rate of weight gain slightly, but the effects on relapse and mortality are unknown. The standard RUTF meeting totally daily requirements may improve recovery and relapse compared to similar RUTF given as supplement to usual diet, but effects on mortality and rate of growth gain were not clear in synthesizing this systematic review in 2019. Here is again a study which was done in India, case study to assess the performance of nutritional center. Here you can see the effectiveness of these centers is this, that the 4 out of 46 NRCs were assessed, and it came up with the result that the mean percentage gain of the weight was 11.6%, where with the mean duration stay was 10 plus 3.7 days. I mean, up to 2 weeks, and the improvement in weight was about 11.6%. What are the UNICEF nutrition strategy for 2020 to 2030? Basically, they emphasize to strengthen the system, the 5 key system. They emphasize the strengthening the capacity and accountability of 5 key systems. These key systems are food, health, water, sanitation, education, and social protection. And they ask to strengthen the system to deliver the nutritious diet, essential nutrition services, and positive nutrition practices for children, adolescents, and women. This is a strategy of UNICEF for 2020 to 2030. Here you see UNICEF emphasizing that children need diverse food from at least 5 out of 8 group of 8 food groups to grow and develop and learn. Here you can see here there are 8 food groups, and out of these 5 plus groups are needed for normal healthy growth. The first, most importantly, you can see here is the breastfeeding, and second is the bread or cereals. Third one is the vegetables. Fourth is the meat and fish. Fifth is the nuts and grains, and sixth is the egg and nut products. Seven is the fruits and fruits, and particularly, and 8 is the milk and milk products. So at least 5 out of them are needed on daily basis for the children for their growth and development. As you can see, although it's a good news for this area also, particularly in South Asia, but overall also there is an increase in breastfeeding practices by 20% in last decade as compared to 2005, 2018. You can see here the comparison of various areas all over. And there is a better increase in breastfeeding practices there. But still, that in spite of that, you can see here the other, the food groups. 60% of children worldwide are not fed nutrient-dense food like egg, meat, or fish. In this figure is the worldwide, and you can see here the 46% worldwide are not fed any fruit or vegetables. And 2 out of 3 children aged between 6 and 23 years, which is most vulnerable age group for malnutrition, are not eating food from the minimum number of food groups. The youngest children between 6 to 11 months have least diverse food. And that's have been concluded in the UNICEF document. Here are my references for today's presentation, and it's time for multiple choice questions. The first question is vitamin D deficiency can often be found as a single nutrient deficiency, that is, any otherwise well-nourished person. The main reason this can happen is because there are four options for you people. You can read and come up with the best one.
C.
Yeah, it's a C basically. That, as you know, the vitamin D doesn't come out from the food. It's mainly dependent upon the exposure to sunlight. So the most appropriate answer here is the C. Second question is the WHO recommends zinc supplementation for which group of people here? The groups are mentioned. That's B. Yeah, malnutrition and diarrhea. Zinc is very important because for the children and is a part of rehabilitation phase for. You can see that diagnosis of iron deficiency in anemia can be complicated by concurrent infections, since many markers of iron status are altered by infections. Can you tell me which of the following combination of iron status marker is likely to be found in person with both iron deficiency and severe acute severe infections? The combination of lab diagnoses are given.
C.
A. C.
Actually, A is the correct answer because, yeah, the A is the correct answer because when the iron deficiency is there, along with the infection, although the hemoglobin is reduced, but all the other markers are increased, like ferritin or the ferritin receptor or hepcidin. And which one of the following gut hormone is responsible for promoting appetite there? If you have heard about it, any hormone like this? Leptin, ghrelin, peptide, CCK.
It's B.
It's B, ghrelin, yeah? Ghrelin is a hormone which increases appetite. It's correct. And you know which of the following nutrient factor has been shown that to best predict long-term morbidity and mortality? Any guess? If you know it, what?
A.
E.
A.
Actually, the total people consuming fat intake more than 30% of the calories are more prone for morbidity and mortality there. A UNICEF model of causes of malnutrition identifies several levels of causes, immediate, underlying, and basic. Which one is not underlying cause of UNICEF model?
A.
That's correct. The rainfall and for agriculture doesn't have to do anything with the UNICEF model. Which one is the statement is correct about this F1775 formula here? You have learned about it?
B. A.
Yeah, it gives us 75 is the D, it's the correct answer. A is the 7.5 kilocalories, D is the 75 kilocalories and 0.9 gram proteins per 100 ml is the correct answer. And same answer, question about F100 formula. 100 calories, D, that's correct. 2.9 and 100 in 100 ml. Zinc manifestation, you know, which one is not there?
B.
D.
D.
C. That's the correct answer. Paresthesia is not associated with zinc deficiency. A patient who has decreased intake of animal protein and increased intake of whole grain roast, cereal, and salad over the last 12 months, which micronutrient deficiency is at risk for? Micronutrient.
Iron.
Any other person?
Calcium.
B12.
B12. That's the correct answer. B12 is the only vitamin which is derived from the animal food and not of plant origin.